Hello, everybody. Sjogren Europe Board is very happy to welcome you to our vaccination webinar. Professor El Kayam, head of rheumatology department at Tel Aviv Medical Center, will give an overview of vaccination for patients with autoimmune rheumatic diseases and an update of what is known so far about COVID-19 vaccines. At the end of the presentation, we will have a question and answer session. If you have any question about the presentation and the topic, you can ask them in the question and answer box. This webinar was organized with the help of unrestricted grants from Serbia and Norway. Thanks to them for their trust and support. Sjogren Europe strictly follows the FPI code of conduct between the pharma industry and patient organizations. Sjogren Europe and the content of this webinar are totally independent from these companies. So now let's start with the presentation. Professor El Kayam, welcome.
Okay, thank you very much, and thank you for this very kind invitation. I want to share my screen now, and I will give you an update on I will give you an update on the. Okay. I will give you an update on the EULAR recommendation for vaccinations in patients with rheumatic diseases. This will be the first part of my lecture, and the second part dedicated related to the COVID-19 vaccine, because I think it is a very hot topic, and I'm sure that you have many questions about that. So this is my disclosures. So as you all know, there is a very real revolution mostly in the field of inflammatory arthropathies, but also in other connective tissue diseases. And although these drugs have changed the we treat our patients, they've also been associated with side effects, mainly increased risk of infections. Probably due in most of the cases to the underlying to the immunosuppressive treatment, but also sometimes to the underlying disease. Infections are respiratory tract infection, including pneumonia, skin and soft tissue, urinary tract infection, herpes zoster, of course, and HPV, mainly in lupus patients. And we can't any of these about patients with rheumatic disease is relatively low. For example, in the Comora cohort, which is the cohort of more than almost 4,000 patients with RA over 17 countries, the uptake of the mean uptake of pneumococcal vaccination was 17%, which is very low. And of course, the range was from 0% in Morocco to 6% in France, and the uptake of influenza also is so high as we would like. The mean uptake was 25%, from 1% to Morocco to 66%. So this led us, our group, to establish, in fact, this led the EULAR to endorse a task force to formulate vaccinations in patients with disease. The first recommendation was 2011, and they were updated in 2019, and I had the honor to be the chair of this task force, and I will present the recommendations of this task force. So the task was composed of representatives of 10 European countries. Most of us were rheumatologists, but there was also two clinical immunologists, one infectious disease specialist. And in fact, we performed a very thorough systematic literature review in order to look after evidence of prevalence of vaccine preventable disease, patient with rheumatic disease. So whether are some diseases such as pneumococcal disease, for example, more prevalent in patients with rheumatic disease. We try to update the data that we had on efficacy and safety of specific vaccines. And of course, a question which is very relevant is the effect of DMARDs on efficacy and safety of vaccination. So the risk of specific infections in predefined groups of patients. So we, in fact, look after the published in fact all the rheumatic diseases. Know that you can see here, this is a autoimmune inflammatory rheumatic disease, and we also look after all the immunomodulating agents that are used or have been used until 2019. And of course, we looked for all the evidence on vaccines are recommended for the adult population, and we have the list here, including inactivated and live attenuated vaccines. So we look for outcomes that affect immunogenicity, which is the capacity to produce humoral and cellular immune responses. And in fact, most of the studies that we have today is about immunogenicity because it is very hard to prove efficacy. You need a very large number of patients in order to prove efficacy of a certain vaccine. And of course, we look at after the issue of safety of vaccine, which is very relevant in patients with autoimmune disease. So in the end, we formulated 6 overarching principles. One is that the vaccination status and the indication for further vaccination in patients with rheumatic disease should be assessed yearly for the rheumatology by the rheumatologist. We think that every year the rheumatologist must try to make with the patient a plan of vaccination. We need to vaccinate every year. We do for the status of pneumococcal vaccines and others. So it should be assessed every year, and it should be done by the rheumatology team because we feel that the rheumatologists and its team, the nurse, the rheumatologist, aware of the effect of the DMARD, of the effect of vaccines on the GP is very reluctant to administer a vaccine without the support of the rheumatologist. The second must take part in this informed decision, and in fact, implementation of course depends on the approval of the patient to receive the vaccine, and this should be in fact a project of the rheumatologist, of the team of the rheumatologist, the nurse, the patient, and of course the GP in order to administer the vaccine. We think that patients should receive the vaccine when they are quiescent in terms of the disease. It is quite a problematic recommendation, I would say, because patients that are about to start immunosuppressive drugs are not very suffer from active disease. On the other hand, it is the best time to start them. So we have to be smart to apply this principle. For example, in patients who suffer from RA or colitis or psoriatic arthritis, even if they are active, can be vaccinated. But perhaps for patients with lupus, for example, or with very active lupus nephritis, we may want to wait a little bit until the disease is more stable before we vaccinate them. The fourth principle refers to the effect of immunosuppression. I mean, to try to vaccinate our patients before starting immunosuppression. It's not possible, and most of the do not really impair the immunogenicity of the vaccine or the humoral. For example, it really doesn't affect the it is very
Professor Al-Khayyam, sorry to interrupt you. We cannot hear you clearly. The voice and the line is very bad. So can you please try to have a speaker or earphones, because we cannot hear you. Your line is very bad.
I don't know why. I give a lot of webinars and I never had this problem. I don't know what to do. Is my sound.
Your voice is interrupted, comes and goes out. It is your line.
Well, I don't know what to do. Sorry. I will try perhaps with the earphone, but I'm not sure that it will be better, but I can try. Sorry, a moment, please, okay?
Yes, okay.
Please. אומרים שהם לא שומעים אותי, שהקו לא גרוע.
נשמע.
Can you hear me now better? Or? Can you hear me now?
It seems to be better now. If you can speak a little bit more slowly, it would be probably also better.
Can you hear me now? Is it better? No? How can you? Is it better now?
Yes, it is better now, but just try to speak slower, please.
I will speak slower. Okay.
Okay. Okay.
Me to start from the beginning, or
Alice, do you want to start from the beginning?
Yes, I think it's better to start the presentation from the beginning, because we couldn't understand. Yes, and if someone use your internet connection in your home, it would be better to ask this person to stop, because
yes,
and to keep the video off also.
Okay. Okay.
Thank you. Thank you.
So let me know if you don't hear me. And okay, so I will start the presentation from the beginning. I'm sorry for these technical problems. I hope that you're hearing me now. So I would like on vaccinations in patients with rheumatic diseases. I think it is very important to. It is very important to know the issue of vaccination in patients with rheumatic diseases, because as we know, there is a real revolution in the field of diseases, and many drugs, biologics, small molecules, and others, and which have improved the outcome of patients with rheumatic diseases. But on the other hand, there is an increased risk of patients with rheumatic diseases to these immunosuppressive drugs. And we have to be aware of the fact that the most common sites of are disease, urinary tract, herpes zoster, and HPV, mainly in patients with lupus. So some of these infections may be prevented by a vaccination, and we know that the uptake of vaccination is very low among patients with rheumatic diseases. From the Comora cohort, which is a cohort of about 4,000 patients with RA over 17 countries, have shown that the uptake of vaccination of pneumococcal vaccine is about 17% only, which is very low. And the uptake of influenza vaccine is about 25%, which is also very low. So this led the RULA to formulate recommendations for vaccination in patients with rheumatic diseases. The first set of recommendations were published in 2011, and these were updated in 2019, and I had the honor to be the chair of this task force. So this task force was included 30 European countries, and most of us were rheumatologists, and we perform a systematic literature review on the evidence of the prevalence of vaccine preventable disease, and we look for data on all the vaccines that are available in patients with adult disease, and the different studies that we performed in patients with all the rheumatic disease, and etc., etc. And this is the list of the diseases that we look after. This agent that we look after, and also the list of vaccines. As you know, we have two kinds of vaccines, inactivated vaccine and live attenuated vaccines. And of course, outcomes such as efficacy, which is a prevention of disease by vaccinations, immunogenicity, which is the capacity of vaccine to induce a response, and the safety, of course, of the vaccines. So we came out with 6 overarching principles. The first overarching principle refers to status and indication for the vaccination should be assessed yearly by the rheumatology team. This is a responsibility of the rheumatologist to vaccination because he is the one who is the best aware of the literature on the efficacy and immunogenicity of vaccines and on the effect of the different DMARDs on patients, etc. So it should be performed every year. The second principle refers, of course, to sharing the patient, which of course very important. And in fact, all the vaccination program should be explained to the patient and providing the basis for and then be implemented jointly with the primary care physician and the patient. The third principle refers to the timing of the vaccine, is referred to the activity of the disease, and in general, we prefer to vaccinate or to recommend vaccination when the disease is stable. It is not always possible, and in cases of patients with RA or spondyloarthritis, ankylosing spondylitis, psoriatic arthritis, we think that it is not a problem to vaccinate the patient when they are active. But for example, in patients with lupus, reactive lupus, with lupus nephritis, we perhaps should try to wait when the disease is more stable in order to administer the vaccine. The principle number 4 refers also to the timing of vaccination, but with reference to the immunosuppression. And in general, we refer of patients before the start immunosuppression, because we know that many immunosuppressive agents may impair the immunogenic response. However, you must know that there are many studies on the effect of methotrexate, TNF-alpha blockers, tocilizumab, anti-IL-6, abatacept, small molecules, and rituximab. For most of them, they do not really affect the immunogenicity of the vaccine. For example, you can see here that the TNF-alpha blockers do not influence the efficacy of the influenza, and they do not really influence also the effect of pneumococcal vaccine, perhaps a little bit, but not so much. Methotrexate may impair the response, but also in most cases the response is appropriate. And the same for most of the drugs. The drug that really impairs immunogenicity is rituximab. We know that the first months after the administration of rituximab, the capacity of the patient to produce antibodies is reduced, and we must take into account when we decide to vaccinate our patients. And we, in fact, we try to patient is on rituximab, we try to vaccinate him when if he is after 6 months after the last dose of rituximab. In general, as I said before, non-live vaccine can be administered to patients with autoimmune rheumatic diseases, even when they use corticosteroid or DMARDs. You must be aware of what I said before about rituximab. And live attenuated vaccines in general may be considered. We must be very cautious with the use of live attenuated vaccines in patients with autoimmune rheumatic diseases. But for example, concerning the Stavax simple zoster, it can be administered in a specific situation, not under biologics, but yes, it can be administered in patients with methotrexate or treated with methotrexate or leflunomide, for example. And some cases of MMR may be considered in specific situations. Okay, now I would like to refer to the specific recommendations. So we, of course, recommend the patient against influenza, and we think that, in fact, most or all of the patients should be recommended to be vaccinated against influenza. And there's a lot of evidence on the efficacy and immunogenicity of the vaccines in RA, lupus, vasculitis, and in most cases, the vaccine induces a good response in most patients. There are some studies which have shown that it can also prevent complications of influenza, mainly in patients with RA and lupus. The use of pneumococcal vaccine, and there are some very nice studies which have shown that there is an increase in pneumococcal disease in patients with lupus and in patients with RA, mainly in patients with lupus, and there is there are many studies which have shown many that the vaccine may induce immune response in patients with RA, lupus. You can see here psoriatic arthritis. There are studies on the efficacy of the pneumococcal vaccine, which have not been very. There is one randomized control study which did not demonstrate efficacy of the pneumococcal vaccine in patients with disease, but there are some retrospective studies which have shown that this vaccine can reduce the development of pneumonia among patients who are vaccinated. So nowadays, we recommend to vaccinate our patients with what we call a stepwise pneumococcal vaccination. We recommend to start with the PCV13, which is a conjugated vaccine, the Prevnar 13. And after 8 weeks at least, we recommend to administer the pneumovax, which is it's a more known vaccine, and it is in the market for more than 20 years. But if the patient has already received the pneumococcal vaccine, he has to wait at least 1 year before he receives the conjugated vaccine, the PCV13. Okay, concerning the tetanus toxoid vaccination, the patient should receive the tetanus vaccine in accordance to recommendation for the general population. There is no special recommendations for patients with rheumatic disease, and for patients also it should be administered to patients who are at risk, mainly, for example, health workers and etc. We should consider vaccination against herpes zoster. As you know, there are two kinds of vaccines against herpes zoster. There is a live attenuated vaccine, the Zostavax, and there is now the Shingrix, which is a non-live vaccine. However, not available. Israel, it is not available, and we still use the live vaccine, and it can be administered, as I said before, in or on the well, in this year of the pandemics, we do not really travel, but until 1 year, the issue of vaccination of traveling to exotic country was very relevant, and the yellow fever vaccine is a live vaccine. It's a vaccine, and therefore should be generally avoided in patients with disease. Although some patients in which it may administer, but in general it should be avoided. And concerning HPV, the vaccine, there are very nice studies which have shown that HPV is more prevalent in patients with lupus, and therefore to vaccination in accordance with recommendations for the general population, but specifically a patient with lupus are at its risk of HPV, they should be highly encouraged to receive the vaccine. Another issue that is important here encourage the members of immunocompetent household members of patients with rheumatic diseases to receive vaccines according to national guidelines. For example, to receive a vaccine against influenza, to try try at least to create a sterile environment of the patient, and in order to prevent infections. The only exception, of course, is for oral polio vaccine to babies, to newborns, and this is where the parents or the family member or household member is the newborn should not receive the oral polio. But for the rest of the vaccines, we should encourage the household members to be vaccinated. And the last recommendation refers to the use again of live attenuated vaccines during the first 6 months of life in newborns of mothers treated with biologics during the second half of pregnancy. We know the biologics cross to the placenta after week 26, 28, and where the mothers receive biologics, and if they receive mainly monoclonal antibodies until the end of the pregnancy, the newborns should not be vaccinated with live attenuated vaccine, and this refers mainly to the oral polio and the rotavirus, which is also a live vaccine. So, in fact, in this update, we make on the responsibility of the rheumatologist to plan, to have a vaccination plan, to share the decision with the patient. There is this new recommendation of both the stepwise approach for pneumococcal vaccines, and there is a more flexible approach to certain live attenuated vaccines, and of course, issue of household members and newborns that is emphasized also in these recommendations. I would like now to switch to the COVID-19 vaccines. I know that this is I think that it's a very hot topic, and as you know, in fact, there are 4 vaccines for COVID-19 vaccine who have published their phase 3 studies, and at least by the FDA and by the EMA, and we have the RNA vaccines of the Pfizer and Moderna who have been approved in the US and the adenovirus-based vaccine AstraZeneca, which is in Britain, and the Janssen, which is now in the process of being approved. I just want to try to explain to you what is on what assumptions are based on this vaccine. First of all, I'm sure that you heard about that, but I would like to explain that the COVID virus, in fact, has these little spikes here, which make this is why it looks like a corona, a crown, and we have the spike protein, the S protein, which is in fact the ligand to the target cells, and so most of the vaccines, at least the 4 vaccines that we have now, are based on the neutralization of the S protein. The adenovirus based vaccine from AstraZeneca, for example, in fact, it is based on a vector, which is the adenovirus, which is inactivated and is harmless, but they have been incorporated DNA, which encodes the S protein. And the same for the RNA vaccine. You know, what is the RNA vaccines? In fact, what is RNA? In fact, our genes are composed of DNA, and they proceed through RNA. I mean, they give the order to create proteins, for example, through mRNA. So the idea of the mRNA vaccines, in fact, to create a very small messenger RNA, which can encode only the spike protein. So when the vaccine, this very small particle of messenger RNA, is inoculated to the muscle, for example, to the muscle, this RNA penetrates the cell, the muscular cell, and this cell produces produces the S protein. Our body identify this S protein as a foreign protein, and it produces the antibodies against it. And the next that will meet the virus, we will be able to produce antibodies and neutralize it. So this is the idea of the RNA virus. So the RNA virus, after a few hours, is in fact is cleaned up, and it cannot penetrate the genes or anything else, and it can only code protein. So all these, there are a lot of fears, and a lot of people are scared about, well, it is genetic, it can change the genetic, our genes, etc. This is not true, of course, because it is only a very small particle of messenger RNA, which is cleared up after a few hours after it is inoculated. So how can we explain the fact that in only after 3-4 months or 6 months, 1 year of pandemics, we have already such big studies on RNA vaccines or AstraZeneca, and there is some groups of patients who are reluctant and don't want to be vaccinated. They believe that these studies were not good enough, and this is not true. In fact, we must remember we are in the mid of pandemics, and this allow us to really to make a very quick study, because if you, for example, if we compare two vaccines against the pneumococcal pneumonia, for example, we need really many in order to prove that it can prevent pneumonia, because we are not, because it's not pandemic. I mean, there are cases of pneumonia, of course, but it's not a pandemic like it in the case of the COVID-19. So in the case of COVID-19, it is not so complicated or so difficult to prove that it is that this vaccine, if they are effective, in fact, that they can prevent infection. In all these 4 vaccines that are been approved, in fact, they have presented phase 1 study, phase 2 studies. I mean, all the phases that are really in fact recommend or we approve vaccines. I just want to comment a little bit on the Pfizer study. As I said before, an RNA vaccine, and enrolled more than 44,000 subjects. It is a very high number of patients. If you compare, for example, the study of the Prevnar, the vaccine against pneumococcal pneumonia, it included only 34,000 patients, subjects. So it is a very high, very big group of patients, 44,000. And in fact, it included also patients above the age of 56. More than 40% of the patients were above the age of 60 and 70. There was a balance of racial and ethnicity profile, as you can see here. And you can see more than 10 patients are above the age of 66, which is quite important because this is the target population that we want to prevent the vaccine. And you can see, well, in terms of safety, most of the adverse events were local adverse events, and they occur usually the first, second, or third day after the vaccine, and they went away after less than 1 week in most of the cases. And the same for fatigue or headache or fever, which was usually after 2-3 days and no more than that. And you can see here very well here, for example, what happened after the first day after vaccination, the second day, and then on. And you can see that after the 6 day or 7 days, in fact, all these side effects went away. The other adverse events. There were, of course, some specific adverse events, but they were very rare, and in fact, there were not very big differences between the placebo group and the vaccine group. So, well, this is in fact and of course the most important result is the efficacy, and the efficacy of the in prevention of COVID-19 was 95%, and in fact it was very significant 7 days after the second dose, and the results are really amazing. I would say, and it seems that nobody thought that we would achieve such a good results, and the data are very similar for the Moderna RNA vaccine. They're a little bit lower for the AstraZeneca, but they're also quite good for the AstraZeneca. In the AstraZeneca, the problem was that performed the study, and the results in South Africa were a little bit lower than in the other countries. But if we refer to the results in South Africa, results not as good as for the Pfizer and Moderna, but not very far from them. So I have to move on because I think we have no time. And I just wanted to say that, as you know, in Israel we have had a very good campaign against for the COVID-19 vaccine, and now up to a few days ago, 53% of the population have already received the first dose of the vaccine, and about almost 40% second dose. And we have recently published data from real life from Israel about the efficacy of the vaccine in real life. We all know that the setup of a research and clinical trial is always better than real life, and you can see here that in this study, in fact, all persons who were newly vaccinated during the period from December to February were matched to unvaccinated patients in a 1:1 ratio according to demographic and clinical characteristics, and were documented infection with COVID-19, and also symptomatic COVID-19, a COVID-19 related hospitalization, illness, deaths. And each group included 596, more than 596,000 persons, which is a very large number. And you can see here that the estimated vaccine effectiveness of the study outcomes at days 14 through 20 after the second dose was a 92% prevention of illness, 87% prevention of hospitalization, and 92% prevention of severe disease. So these are very good results, and this is real life. So impressive, I would say. And just I would like to complete this talk with a point of view that we have just published. A group of the US Force, we have published a point of view on vaccination against COVID-19 patients with autoimmune inflammatory rheumatic diseases, and I will just go through it quickly. The risk of contracting COVID-19 for patients with a rheumatic disease is similar to population, or at most mildly increased with lupus and vasculitis. For most patients with the course of COVID-19 is similar to the background population and is mainly affected by the presence of the classical risk factors such as hypertension, etc. The course of COVID-19 may be more severe in patients with lupus, antiphospholipid, and scleroderma and vasculitis. And also the course of COVID-19 is perhaps more severe in patients who are on mycophenolate mofetil and rituximab, and of course we read the to vaccinate patients against influenza and pneumococcal vaccine, and we emphasize the fact that RNA vaccines are non-live vaccines, and from this point of view they are safe in patients with rheumatic diseases. And in view of the COVID-19 pandemic and the possible adverse course of COVID-19 in patients with disease, and in general, the favorable safety profile of population, we think that all patients should be vaccinated against the RNA, with the RNA vaccine against the COVID-19. And only that we have to look after again is the issue of rituximab. It is not contraindicated to receive the COVID-19 vaccine if you are treated with rituximab, but if you can, we should try to vaccinate our patients at least 4 months after the last infusion of rituximab, if you want to have a better response. Of course, we need more studies, and we are now in the process of performing studies. I can tell you that we have in my center we have about 500 patients who have already received the COVID-19 vaccine, the Pfizer vaccine RNA, and can say the number of side effects that we had were very low, and most of the patients did not fear of the disease. Of course, we are now summarizing the results. That's why I didn't present them here, but I think that if you have the possibility to receive the vaccine, most of us should be vaccinated. So I hope that you've been able to hear me despite all these technical problems, and that the lecture has been clear, and they're very happy to take some questions.
Thank you, Professor.
Thank you very much, Professor Elkayam. There are some questions, and I'm sure people are busy typing in the Q&A section. I also have had some email to me. One of them is about an individual who's taking injected methotrexate 20 milligram and injected metipred 4 milligram, and wondered whether or not it was safe for them to have a COVID-19 injection.
Yeah. Well, in terms of safety, it is safe. There is no, in terms, I mean, it's not, it's safe as for the general population. Of course, you know, you can, like the general population can have some side effects, but it is a non-vaccine. So in terms of safety of inducing COVID-19 or something like that, there is no issue of that. And from this point of view, it's safe. The question that you may ask is whether the methotrexate, for example, may impair the response to the vaccine, and we do not have data on that. We know that, for influenza, shown that if you stop methotrexate a week before and a week after the vaccine, the response is better.
Okay.
The sound is freezing right now, Professor Elkayam. Just
okay. Did you hear me now?
Yes.
I think what you were saying is it is safe for an individual to be vaccinated, but to what extent it will work for them if they're on that combination of medication.
Yes.
I have another. There is another one which is asking about somebody who's pregnant. Is it safe for somebody who is pregnant and has primary Sjogren's to have a COVID vaccination?
Yes, well, it's not a very easy question, I would say, because of course all the trials include patients who are pregnant. But on the other hand, there have been many cases of pregnant women with COVID-19 with a very bad outcome, including death. And I must say that from this point of view, the recommendations are different. For example, in the US and in Israel, we recommend to vaccinate patients who are pregnant, people who are pregnant or pregnant women from the first trimester, and mainly in the last year. Most of the severe pregnant with COVID-19 are in the last trimester of the pregnancy. But in Europe, there are more concerns. But there are countries where it's not recommended, or not actively recommended, I would say. So it depends on where you live. We do not really have data. We do not seek, in terms of, in theory, we don't think that it is we think that it is quite safe. But you know, the issue of pregnancy is very delicate issue, and we must be very careful with that. So we do not have data, and there are different approaches from different countries.
Okay. There are several people who are interested in whether there is any difference in between the two major vaccines that are available if they have Sjogren syndrome.
Pfizer and the Moderna? Or?
Yeah, I have to say I've had the AstraZeneca because that's what we're giving mainly in the UK. I've had mine,
yeah.
had a sore arm, slight temperature, 24 hours later, and I've been fine.
Yeah.
So from that point of view,
in terms of efficacy and safety,
yeah,
the profile is similar for the two RNA vaccines. The main between the Pfizer and the Moderna is that you need the condition that you have to keep the Pfizer vaccine more. You need to keep it in -7 degrees refrigerator, and the Moderna it's only -20. So it's a little bit easier perhaps than Moderna. But if you have all the logistics, in fact, it's more or less the same, at least in terms of the clinical trial that you have. Of course, there are no head-to-head trials between Moderna and Pfizer. The results that I have reported here in Israel, for now it's for the Pfizer vaccine. We are now starting to use the Moderna, but most of the 5 million people who have been vaccinated here were vaccinated with the Pfizer vaccine.
Okay, in Britain, they're now producing some evidence with the AstraZeneca vaccine, which is showing the results are very similar so far in the elderly to the results you've produced in Israel with the Pfizer. And I think that the other side of that question is presumably whether or not somebody is on immunosuppressant medication, depending what it is, may impact on which vaccine might be suitable or whether they should be vaccinated.
We think that it should be okay. As I said before, we have data on the influenza and the pneumococcal vaccines and hepatitis. We do not have data on the COVID-19 yet. I hope that we'll have next month, because we are now summarizing the results that we have for 500 patients. So I hope that we'll be able to publish some information on that. As I said, for influenza vaccine, most of the symptoms are not significantly affect the immunogenicity. The only effect is a rituximab. For alpha, as it reduces a little bit the influenza, it is not very significant. That's what I want to say. So we definitely recommend the vaccine, even if you are receiving immunosuppressive treatment. Do recommend to. Of course, it can be decided by case, but in general, we do not recommend to stop the treatment.
Okay. If we've got one question about immunoglobulin deficiency. If somebody is immunoglobulin deficient, will they be able to respond properly to the vaccine?
One very good question. You know, we think response to the vaccine is not only the humoral response, I mean, the production of antibodies, but also the cellular response. And for COVID-19, specifically, the cellular response may be as important as the humoral response. And so it is recommended also to vaccinate patients who suffer from hypogammaglobulinemia, for example. We expect they may have a lower response to the vaccine, but we hope that they will have some kind of cellular immunity, which may confer some protection. So the official recommendation also to vaccinate patients with hypogammaglobulinemia. Yes.
Okay. There are concerns from some people because in the UK, everybody is sat down and asked what if they have any autoimmune disease when they go to be vaccinated. And I think probably you've answered it already in a sense that if they have autoimmune disease, is it dependent what medication they're on, whether or not it is safe for them to be vaccinated? I think
as I said, I think I answered that.
Yeah.
It's not a question of safety, really. There is no. It's not a question of safety in terms of the treatment that you receive, because, as I said, it's a non-life, so it cannot use disease. In terms of fear of the autoimmune disease, we of course do not have enough information, but in general, again, I must say that from what we know about influenza, pneumococcal vaccine, hepatitis, HPV, etc., it doesn't really induce a flare in most cases. So that's why we think that it should be administered, yes.
Okay, and then I've got an interesting one. We have a question from somebody who's involved in a trial with iscalimab, and that individual is concerned whether or not it's safe for her to be vaccinated. I think the safety here is not a question of whether the vaccine itself will do any harm, because I think there's lots of evidence that says they won't do any harm other than perhaps a minor side effect when they're given. Yeah. But whether or not it's actually safe with that particular product, or whether
what trial? I didn't get it. What
iscalimab, ISCALIMAB. And like most of us, we're keen to be vaccinated because we don't want to get COVID.
I agree. But I think that, as you said, the main issue should be perhaps about how it can affect the immunogenicity, but in terms of safety, there is no really issue.
So the question is, for anybody who's not sure, they need to discuss it with the clinician who is prescribing the product. If you're not sure, yes, go and discuss it with your doctor, your rheumatologist.
Yeah, I agree with you.
They will advise you, and if you do that before you get called for the vaccine, if you haven't already had it, then that will give you time to alter a dose or suspend treatment for a short period of time. Is that a reasonable summary?
Yeah, absolutely.
Thank you. I think that's very helpful. I'm just looking to see if we've got anything else coming up or if we've managed to answer them. Somebody here, this is interesting. Somebody who has primary Sjogren's and MGUS and had a very interesting reaction after the first dose of Pfizer. This person felt very thirsty, had IBD and esophageal reflux. Could this have been provoked by the vaccine?
It's difficult to say, to tell, of course. It's difficult to say. For example, in my country, I'll say nowadays, most of us are after vaccine or after COVID-19. So, you can always say that it is because of the vaccine or because of COVID-19, but it can also be not related, because millions of people who are now vaccinated, it's very difficult. So I think that if you have the side effect that is often reported, okay, in the end, it can be related to the vaccine. But if it is one case, we have to wait. We have to wait for more information to be sure about the connection between the side effect or possible side effect and the vaccine.
Okay, I'll say to that lady who posed that question, if you live in the United Kingdom, there is something called a yellow card scheme. If you want to report that reaction, then they'll be able to check if other people have had it. If you go and talk to probably your GP and ask them, will they report it? And then we have one more, which is a question about if you have hypergammaglobulinemia, and a low amount of lymphocytes, are you okay to have the vaccine?
You are okay, the same. It's the same.
Same. Okay.
That you are even, I mean, you are more prone to have complications from the COVID-19 if you have lymphopenia. So you should receive the vaccine. Yes.
Okay. So I think if I can summarize, because I think we've got to the end of the questions. I think the summary for me is, if you have any concerns, talk it over with whoever is looking after your care, whoever is prescribing the drugs for your autoimmune disease, and otherwise have the vaccine. And for most of the people who have a concern, they're likely to be told it's safe for them to have the vaccine. The difference is your immune response may not be quite the same as somebody who doesn't have the disease, in the same way as the immune response, and if you're older, may not be the same, although both the Pfizer and the AstraZeneca, and I'm assuming it's going to be similar with the Moderna, because it's similar to the AstraZeneca, they're finding that even in the elderly, the ones they're always worried about who have weakened immune systems, the immune response is significant. So I think the plea is, please go and have your vaccine when you can, and make sure you go back for your second dose. Is that?
Yeah, I agree with you. It was a very good summary, and I agree with you completely. And I would like to encourage you to discuss with your physician. If you are reluctant or scared, you can understand that. But first, well, yeah, we have to remember now that we are not in the same situation that 3 months ago. There are millions of people who have been vaccinated, and in fact, the results are quite good, and there are not so many side effects. And to stop this COVID-19, in fact, really, this is the only solution that we have. And if you are reluctant, okay, you can discuss it with your physician, but try not to be to take your decision according to fake news and all these anti-vaccinations are in the net, and try to be informed by people who really understand about vaccinations. And of course, we do not know everything. No, I am sure that we are learning every week. I would say every week there is new information, and this is an evolving situation.
Yeah.
But we have to be positive about that and to discuss this issue with the physician and in order to make the correct decision.
I'm going to throw one extra question at you, Professor El-Kayam, which has just come in. And this is a different one. It's a question, is it safe to be given Sputnik 5 if you have lupus?
Well, this is a very good question that I cannot, of course, answer really with data. You know, the Sputnik is also the adenovirus. In fact, it's the same technology or similar technologies as in the AstraZeneca. We think that in general, vaccine, well, I think that my answer will be the same for all the vaccines, not specifically to Sputnik vaccine, the AstraZeneca, or the RNA vaccine. I think that patients with lupus can be vaccinated. I think that if the patient is very active now, very active in lupus nephritis, perhaps it should be postponed, because we do not want to provoke the immune system, and it should be discussed with the physician. But if you have a stable lupus disease, I think, well, we are now vaccinating our patient, and we recommend them to be vaccinated. Because as I said before, there is a population of patients who are more prone to have complications from the COVID-19. These are patients with lupus. And so we have to protect them.
Thank you very much. I think that definitely is all the questions. And I'm going to ask Alice. Alice, do you want to do the thanks?
Yeah, thank you so much, Professor El-Kayam, for this presentation. Sorry to everybody about the technical problems. We will upload the slides on our website. I think Professor El-Kayam will be okay to send them to us.
Of course, yes, of course.
And thanks to all the participants to to attend this webinar. Linda,
Thank you. Thank you.
final word?
Thank you very much.
Thank you very much for the invitation. Bye bye. Good night. Bye bye.
Good night.
Goodbye.